My name is Carl Christensen, Oregon HFMA board member and Chief Operating Officer at Professional Credit Service. It's my opportunity to introduce our speaker for this session, Travis Gentry. He's the co-founder of FHS Corp and a pioneer in patient estimation technology. Travis is now the CEO of Hy-Vee Health, offering innovative platforms like the Vitality Payer Scorecard, GFE Exchange, and Insight CMS Price Transparency. With a background in electrical engineering and an MBA, Travis has contributed to an AI and machine learning through his neural network research. Please welcome Travis.
Thanks for having me. I appreciate the opportunity to still be able to speak with you. I got stranded in Minneapolis myself on my way to meet you. Otherwise, I would be there. Part of what we're going to go through today, and a lot of these slides won't apply because they're more fun in person, but we'll still go through them anyway, is to talk about kind of the sorry, I got bad internet. Is to talk about what's going on in the industry related to payer accountability. We're going to blow through some of these slides, but we are going to be talking about data. And one of the things that we have to be careful about data is that statistics can be misleading. So I'm just going to give you all a minute with this. You can laugh in the chat if you thought it was funny. That's about the only way I'm going to get any feedback here. Otherwise, I'm just going to monologue to you. What usually is kind of a general, more informal session. But part of what I want to talk about is what's happening in the environment as relates to payer accountability. And part of what we see today, and I think this has happened since coming out of COVID, but is starting to emerge before, was that the relationships between payers and providers have continually to be strained. And I think there's been some recent surveys, even at the end of last year, that started to measure this, and that the majority of providers believe that their relationships with the payers have worsened. And a lot of it's because of the behaviors that we see around denials, timeliness of payments, authorizations, things of that nature. Even to and up including a couple of weeks ago, the CFO of Common Spirit just basically said there's never been a more challenging system than the environment within healthcare today. Part of what I am going to ask you to question, right, in the spirit of Ted Lasso, let's be curious, is how do we know? I'm not here trying to communicate or tell you anything that you don't individually know about your hospitals or your health systems. What I am going to challenge is how do you know if your hospital's experience with the payers is better or worse than that of your peers? That is the real challenge that we're trying to evaluate. We need to understand what good is in order for us to get better. And when we just have a very myopic view by just looking at our data and our experience with the hospitals, it becomes difficult to understand what is happening outside of your organization. So part of it is normally what I ask is, who has the best denials, meaning the lowest, right, in the state of Oregon? Who has the worst? It's a question today that is literally unknowable. If we want to understand prompt pay laws, if we want to understand timeliness of payments, we need to be able to understand, and I'm going to assume, somebody can put it in the chat if you know, but what is the overall prompt pay law in Oregon? Anyone? Put it out there. If you know it, type it in the chat. Oftentimes, these values are somewhere in the neighborhood of 30 to 45 days. So let's just assume in Oregon it's 30 days. What I would question is, why is it 30 days, right? 30 days, maybe that's great if we're sending claims and receiving remits through the Pony Express, but it's actually a ridiculous number for providers to sit here and wait to get paid when you are submitting claims electronically that literally happens in seconds, and all of a sudden it goes into ether and you don't hear back for weeks, and in some cases, months. So it's the ability to measure this type of behavior. And it really comes down to understanding your experience, the me versus the we, or the trees versus the forest. And what we're going to talk about is access to a data set that doesn't exist and that we need to go create. If we look at the bar in the industry, about a year ago, Premier launched this national survey about denials, and it got a lot of press. It got a lot of people who were responding to the behaviors from denials. And the challenge is that the data underlying this really should be questioned. It's back to Ted Lasso. Let's be curious, right? Because if you look at the graph just at face value, right, this is indicating that these are the denial rates from October through December of 2023. That's kind of what it says. That's the source of this data. But when we're curious and we dive into this, what we really see is that they published this study in 2024. They collected the data from October to December of 2023, but the data in the survey was from 2022. It's egregious. It's like saying, I want to go buy a share of Microsoft stock today, but I'm going to buy that based off of what was happening a year and a half ago. Not relevant to today. So part of it is that then we further dig and say, how did they capture this information? So oftentimes, right, a common mechanism in the industry is to use surveys, right? So a Excel spreadsheet was sent out to all these providers to say, fill in this information. Well, I guarantee you the way that one of you would fill this out versus somebody else would fill it out is going to be drastically different. We know that we're both trying to identify initial claims or claims requiring pre-auth, but the way that you might query your system and what you might be including or excluding could be drastically different from one provider to another provider, which is why survey instruments for quantitative information are highly suspect and don't hold a lot of credibility with those. But because it's the only mechanism, it gets a lot of press and it carries a lot of weight. My point is, we need to do better than just surveying information. Survey information is great when you want to get qualitative information, but when it gets to quantitative information, it becomes a little bit more difficult. So from your perspective, providers are submitting claims to the payers, and the payers are remitting back the remittances. So you're sending out the 837, get the 835 back. And you, as an individual hospital or a health system, all that you have access to is really just your experience. The other side of this is, what is it from a payer's perspective? Well, the payer has claims that are being submitted from all of the providers across the state, and they have a data set that is more rich, more robust than what your individual hospital or health system has. So it's no wonder that when you go and sit down with the payers and you're either trying to resolve issues around denials, resolve issues, or trying to negotiate a better contract, you're basically throwing rocks at a tank. You're completely outmanned, you're out analyzed, because payers, their whole business of an insurance company is just actuarial science, right? We're trying to leverage the data to identify and mitigate risk. And this is why hospitals are on the losing end of that fight. So I think it's best represented by Bug's Life, where, you know, you have Hopper, and sorry if this is a spoiler alert for any of you, but, you know, the whole premise of the movie is the grasshoppers effectively subjugating the ants. And I believe that this, to some extent, represents what's happening in our industry today, because we have, right, we have hundreds of providers to few payers. And the fact that you outnumber them, but yet they have so much control over the data and over your business, it is very asymmetric, especially from a data perspective. So what's our perspective? Well, I ride a unicorn, and on this unicorn, right, we believe in a world where providers can safely come together to aggregate information and to learn from the collective, to learn from the colony of the hive. And at the end of the movie, right, this is where all of the hospitals need to band together, need to have and share an aggregated data set that doesn't have any PHI in it, that everyone in it is anonymous, but you can collectively use that information to have an apples to apples conversation with the payers. It's the only way we're going to be able to change the narrative. So part of what and how we do with that addresses these 4 elements. You have to create the most credible data set in the industry, which means we need to source that data directly from hospitals. I've had hospitals and health systems time over time saying that the only data that they're going to trust is the data that comes from them. There is a lot of data in the industry, but if you don't have what's called the chain of custody of that data, that you don't know where it's sourced from, then it reduces the credibility of that data. Same thing as if you're trying to approach the payers with survey information that can't be backed up by data. You want to be able to hold payers accountable with payer data, with that 835 data. That is what credible data is all about. The other element is the timeliness of that data. In that, again, a lot of the data that's out there, several providers will sell old claims data. A lot of clearinghouses sell data. We get a lot of, think about CMS and Medicare cost report data that's out there. All this data that exists in the industry is anywhere from 6 to 18 months old. That's not effective for advocacy. It's not effective for any of you in order to say, I've got a current denial problem, or I've got a current reimbursement issue, or a current timeliness of payments issue. I need to have data that is current. And we believe that given that every single hospital sends and receives claims daily, we actually have the ability to create the most timely data set by refreshing this information no less than monthly. The other part is it has to be secure. We don't want or need another change event to happen in the industry. Right? On my unicorn, if I go get every claim, every remit from every hospital, and I put that onto one platform, we'd have the ability to have an event greater than and worse than change if it had PHI. So let's just take PHI out of the equation. Don't want it, don't need it for part of any of this analysis of holding payers accountable. And then finally, we want to create the safest data set, meaning that it's a safe place for a hospital to come, to be curious and say, what is our experience with United Healthcare versus that of my peers in the state, maybe across the country? If I'm a large health system that spans multiple states, I want to understand what the experience of our hospitals in those states relative to the data in that states. But I want to be able to ask that question from an anonymous perspective. Now, one of the things that I always like to have, so if there are questions along the way that any of you have based off of what I've already talked about, please feel free to put that in the chat. So I'm just not monologuing. I'm happy to take any and all questions. I'm monitoring it here. So I'm happy to entertain questions along the way. And even if somebody has a comment, feel free to put it in the chat so that I'm just not here talking to myself in a hotel room. So what's the view from a unicorn? Well, it's a matter of what can we compare. If you think about all the data that exists in the claim and the remit, Historically, a lot of the data that has been available has been discharge information, claim information, had volumes. We could look at, just charges, diagnoses. It was a safe data set. The information that we really are trying to help harvest and to normalize is the remit information. And historically, that information has been off limits. It's been radioactive. And it really wasn't until price transparency came about 4 years ago that changed the landscape of data in our industry. There's still all these antitrust laws that apply, but one of the main things that prohibited any provider from wanting to even entertain this concept was the fact that their reimbursement rates, they felt like could be compromised. And in today's world, you would argue that, at least philosophically, I don't think it's actually happened, is that all of your contracted rates with your payers is supposed to be public information. I will tell you, and it's a personal comment, that machine-readable file data is crap. It's a technical healthcare term. I don't think there's a lot of value in it. I think there's more valuable information that can be leveraged for hospitals who, A, still want to be anonymous, and B, be able to compare reimbursement to that of their peers based off what you actually got paid. But more importantly, how does that data directly correlate to timeliness and payments, prompt pay, and or denials? That's the core information that I feel is out there. So we're going to talk a little bit about some of this data and some of the metrics based off of what we can compare. And then we're also going to address how we can compare it. Part of what we do, the magic of it, is normalizing the data such that data from every single hospital coming through at 837 and 835 is normalized. I guarantee you that the way that each one of you maintains your payer masters and you do your payer mappings is drastically different, right? I still see claims with Aetna misspelled on them. So we have to normalize the data in a way that puts everything into certain buckets based off of the payer type. What are my commercial versus my Medicare Advantage lines of service from the same payer? Being able to normalize the payers. Sometimes within a state, payers can take on different names, but they're really being processed through more of a regional or a national service center. And then it's getting into the specialty and the patient types, and more importantly, even normalizing the categories of denials. We have all these CARC and RARC codes, but we don't have a national hierarchy of how those codes should be rolled up and compared. Again, I guarantee you that you talk to 2 different hospitals, you got 2 different ways of what CARC and RARC codes fall into what categories. And it's very difficult to normalize that from an apples to apples perspective. So we take the Henry Ford approach. You can have any color you want as long as it's black. We're gonna categorize these. And if we need to shift any of them, very open and willing to do that. It's kind of good for the goose, good for the gander type of thing, where we apply a change and it shuffles the cards for everyone in such a way that it's apples to apples. So let's leverage some of this by getting into an analysis of like Medicare versus Medicare Advantage. Jennifer's asked a question, do you have suggestion on how to locate those public reimbursement records? I am assuming that you were talking about these machine readable files. Is that correct? Okay. So part of it to locate these files, this came out as part of, it's kind of like farmers insurance, right? We know a thing or two because we've seen a thing or two. So not only are we in the business of helping hospitals aggregate and normalize their data for a national payer scorecard, but we also create machine readable files for about 200 hospitals today and give them 300 shoppable websites. So we kind of have a little bit expertise in this price transparency world. So I can help you be compliant with a law that I think is complete BS. That's my most honest answer. But to specifically answer your question, One of the new regulations that came out is that everyone is supposed to put in, and the reason why they did this is to make this location of these MRF files standardized, is that there is in the header of your website, you're supposed to put a / CMS hyphen healthcare, it's HPT, healthcare price transparency .txt. So there's supposed to be a TXT file in your root directory, really to enable CMS and their subcontractors to create web crawlers to go across your websites to automatically identify the location of these files and to be able to pull them down and aggregate that. So in order to find it here, and I'm going to type this in. So if my website, was www.hospital.com, right? What I would do is that there would be a / CMS healthcare price transparency .txt file that every hospital is supposed to put at the end of your website to identify those files. So sorry, that was a very long-winded answer. If I didn't answer your question, please let me know. But that's how you find it. But then even when you do find it, trying to download it, trying to extrapolate anything meaningful out of it, I'm going to suggest is difficult. I do think Turquoise Health, give them a little shout out. I think they do the best at that. But I still believe that the data is suspect. I think MRF data is fool's gold, and I'm biased to the information that exists in the claims and the remit data. I feel like that's the real gold. So on to our regular scheduled programming. But feel free to ask any and all questions. So let's get into this. So prompt pay. This is an example. Now, let's say that I have these two hospitals. This is all real information, where my two hospitals are demo 653 and 700. So this gives you the ability to say, what is our experience as individual hospitals or health system compared to that of the state? So I just did this presentation yesterday at the Kentucky HFMA. So I pulled real data out of Kentucky to kind of show them what was happening in the state. And what is important of this, right, is I can understand and set an expectation, because I think somebody had put up further in the comments when I was asking about prompt pay, right? The law is 14 days in Oregon. That's freaking awesome. It's definitely not that short in a lot of the other states. But anyway, so the point is that we can go look at Medicare, for example, and we should have this expectation that Medicare Take Advantage or Medicare Disadvantage should be paying along the same lines as Medicare, but we know that that's not the case. So part of what we're able to highlight in here is discharge to claim, which is nothing more than an internal revenue cycle metric, right? That just says, hey, based off of when the patient discharged, how long does it take your team to code and send off the claim, through a clearinghouse onto the payer. And then we want to measure, well, what percent of those claims get paid the first time through? That's our definition of the clean claim. Claims that have been paid the first time through without any denials. And how fast were those payments? Because we start to see, and there's been a lot of speculation, that we've now partnered with 25 state associations across the country. And there's a lot of discussion around prompt pay laws. And the fear is that if you set the bar to, let's say, a 30 days, right? It's just how close to that 30 days can the payer walk before they get burned? And the data shows clearly on average what this is. For commercial payers, on average, let's just round it up, it's 18 days, right? Medicare Advantage on average is, let's just say it's similar to 18 days. But when we drill down into this at a payer level, right, there are certain payers that I can show you compared to Medicare pay at least a week or more slower than Medicare does. And why? Because they can. But why would I not want to hold on to hundreds of millions, if not billions of dollars in an account earning interest for just one more week, if I can do that. And especially if the prompt pay laws allow me to do that. That's the type of thing that by aggregating our data, it's the only way to see the collective experience of the payer. We don't want to look at this. Now, some of you are saying, okay, we've got Epic. Epic has financial pulse. It's great. That's fine. One, there's a lot of things that it doesn't do. I'm not going to turn this into an us versus an Epic. I'm happy to have that conversation with anyone. But what I am going to suggest to you is Epic and looking only at Epic data is inherently biased. You do not want to look at payer behavior through the lens of Epic, because if Epic is doing all the wonderful things that it should be doing for you, your experience with the payer should actually be better than that of your peers. But the problem is, it's kind of like Coke versus Pepsi. You know, you go to these events, they only serve you Pepsi, and you really want a Coke, you can never get one. Well, that's the problem with Epic, is that you don't know, is there empirical evidence that actually shows that Epic hospitals outperform non-Epic hospitals? Can't tell that by just looking at Epic hospitals data. What you want to be able to do is have an agnostic platform of all different shapes and sizes and types of hospitals, including different shapes and sizes of EHRs. That's the way that you can create an unbiased data set that says, as you go to the payer and understand this is true payer behavior, then you can say, does your experience work differently? So Epic's great. They've got financial pulse. They'll continue to improve it, but it's inherently biased in the data that it has. You need to have more information outside of it. I'd say continue to use it, but also be curious and get non-Epic data when you want to hold payers accountable. So I know this isn't any rocket science, right? Medicare is paying faster with less denials. Duh, right? But what we are able to measure then is quantitatively how much slower does Medicare Advantage pay and how much more do they deny? And then you can ask the me versus the we that says, well, what about my hospitals, right? Is this an issue that is unique to us? Or is it something that's systemic and you can look across the state and see that everyone is having the same problem? That's the reason why the state associations ultimately get behind the platform, why Washington is doing it and why California is doing it, Idaho is doing it, Nevada is doing it. You notice that there's a state I left out. Because you have to aggregate the data to understand so that these state associations can get your data from you in an easy way to advocate on your behalf. That is ultimately what we need to do and what we're trying to do with everyone across the country. Every claim, every remit, every hospital, one place, so that everyone can leverage this data. This is data from hospitals, for hospitals, only for hospitals to measure this. Let's jump into denials. Same type of analysis. I can go look at what the experience of my denials are relative to that of my peers. I can go look at and say, look at the orders of magnitude in terms of denials from my hospitals relative to what's happening in the state, maybe in surrounding states, and be able to translate that and be able to say, it's not just a little worse, it's orders of magnitude worse, right? It's 200 times, it's 300 times worse of these denials in these states. And my experience, you know, is either it's no different, or maybe I have one hospital that's outperforming the state and one that's underperforming. Then the question is, why is one of my facilities having an issue? This might be a me issue. The last thing you need to go do is to be crying wolf to the payer when the payer is going to turn around and try to highlight every potential weakness that you have. Sorry, but my Wyomingism is you got to have your poop in a scoop before you go fight the payer. You have to understand where your own chinks in the armor, where you have potentially self-inflicted issues, because they're going to leverage everything against you. And this is the intent, is trying to highlight that. So if we were to drill down, because again, I've intentionally kept the analysis high level, that I can go into very specific Medicare Advantage payers and show you state by state across the country that they are consistently slower than Medicare, but some are drastically worse than even their peers. This is the information that you might be able to flesh out some of that, right? And you might be able to look at your data and it might correlate to what we're seeing. Or you may have an issue where your experience with these payers is actually 6 times greater than that of your peers, meaning this is clearly a you issue. And if you don't have the ability to ask that question, and if you're not curious to ask that question, you're never going to know. I will tell you that my personal opinion is that the payers have all the providers fooled and that your competition is one another, when the reality is your competition collectively is that payer. And they've been able to keep baby in the corner because you can't talk about these things. You can have these anecdotal informations, and until you're able to bring the collective experience using the payer's data against them, you're never going to be able to change that narrative. Downcoding. So within downcoding, this is interesting. Across the data set, Humana looks worse from a downcoding perspective because they're the only ones brave enough to tell you that they did it. All the other payers, the level of data, like there are certain remark codes that the payer are supposed to put on the line items that says, you know what, we're not going to pay you an ED level 3. We're down coding this to an ED level 2, and that's the rate that we're paying you. So the absence of these codes is actually what's most alarming. And if I drill down into this, it looks like, oh, well, it doesn't look that bad. It's only like 1.5% or 0.5% or whatever the case is. But if I filter this and said, let's just go look at our ED cases and be able to compare across our organizations, across the state, or even across the country, there's certain states where this ED downcoding is in the 50 to 60%. It's crazy. So in this case, and this is all based off of real data, real hospitals participating, this is only when they're identifying that it's happening versus they're doing it and they're not telling you. They're forcing you to go find the needle in the haystack. That's the challenge, right? We have codes and we can identify the payers who are saying that they're doing it, but the absence of those payers that says that they're not doing it right, I'm going to suggest that they're potentially just hiding it. And they're forcing you to go find when they're doing it. And so that's one thing to highlight here in downcoding is that it's really, and I would ask the question, right? Again, try to facilitate a little bit of dialogue. How are you identifying these today, right? I mean, it becomes a very manual process if you don't, and we try to identify, like if you've got the system where you can create an expected allowed amount, right? And I think expected allowables or expected reimbursements, kind of like the Bigfoot of our industry, because nobody actually ever really sees it, but we talk about it a lot. You're saying, okay, for this payer, I'm expecting $3,000 for an ED level 3, and they only paid us a 2. They didn't tell us that. It becomes very manual to go try to find those. Lesser rate of charge. Extremely easy analysis to do. And it's not always 100%, but we flag claims and remits where the charge on the claim and the reimbursement on the remit equal each other, because it just suggests that your reimbursement might have been capped, right? Again, not trying to insult anyone's intelligence, but let's just level set, sing from the same hymnal, right? Lesser rate of charge simply says, if you negotiated a rate for $1,000 colonoscopy and your charges that you submitted towards that colonoscopy were $800, they're going to reduce the rate to that, the lesser of the two, the rate or the charges. And when your charges are less than your contracted rate, they're not going to pay you according to the contract. So you're going to lose $200 per colonoscopy for that payer every time that happens. And again, that could be a self-inflicted issue. Did you make a change to your charge master? Are you not capturing everything in your coding and billing? Or is there something else that's driving it? within 60 seconds, you can come in and be able to identify and drill down to say, I want to go look at this by inpatient specialty and say, okay, I've found a pocket of where this is. I want to further drill down into cardiology and to say, you know what, we've got $86,000 of claims that hit in June that could be hitting lesser rate of charge. It's because those claims, the charges on the claim and the reimbursement on the remit equal each other, and we can just sum it up. And this is one of those deals that, like, that's curable, especially if you capture it, catch it soon enough. And that turns into actual real dollars to be able to go in and identify where that happens. So part of this is trying to provide a little bit of a check engine light for the industry so that as hospitals are coming together, we're seeing a collective experience, allowing individual hospitals and health systems to benchmark against not just themselves, but specifically against the payer, and to say, is what we're experiencing with this payer different than what everyone else is? Part of normalizing the CARC and the RARC codes is actually creating the ability to quantify the difference of denial behaviors. I'm sure that if you were all to weigh in, right, you would agree that payers use the same CARC or RARC code differently from each other, which makes it very difficult in terms of how you and your team address certain issues, because you almost have to have custom workflows on a payer by payer basis. And that should not be happening in the industry. The problem is there's no watchdog in the industry holding payers accountable. And that watchdog has to be not you individually, not the large health systems, but you collectively coming together to say, this is what the data tells us is happening, right? We are looking at the remit data that comes to you from the payer, and all we're doing is just aggregating that and looking at the big picture. This clearly shows on the left with Medicare Advantage, right, that they're, as a payer type, their denials are drastically different than Medicare, with authorization, again, no surprise, being the main issue. But if I were to go compare Medicare Advantage against their commercial counterparts, now all of a sudden, it looks like I might have some correlation between those, because I start to see that it appears, it's not the smoking gun, right? But it appears that the behavior out of Medicare Advantage compared to their commercial counterparts are very similar. Correlation doesn't always equal causation, but it just highlights that. So part of this is you can now have the ability to go back from a revenue cycle perspective and from a managed care perspective to the payers, let alone coming together collectively from an advocacy perspective to start to change behaviors, because now you can identify them. You have evidence that it's basing up. It's no longer the anecdotal little Johnny, you're being mean to me story. It's quantifiable proof that everyone needs to have. So let me summarize this. Part of what we believe has to happen is that the industry and providers need to unite. You need to create a data set that's not only equal to, but better than that of what the payers already have. The reason why they're winning and the reason why you're losing is because they are managing and leveraging their data better than you are individually and especially collectively. They've kept it completely siloed. Their biggest fear, and we've heard this from other state associations, they brought in their payers and they sat them down, they started showing some of this data, and the remark was they went quiet, they whipped out their phones, they started taking pictures, and they're like, where did you get this information? It scares them to death for you to have this type of information, because this is how they've been out analyzing you for decades. And it really comes down to the old Peter Drucker, motto that you can't manage what you don't, or you can't measure. And you're all measuring your individual hospital or a health system information very well. Don't doubt that for a second. But it's internal, right? It's a biased data set. It's the same argument as Epic. You have to have data external to that to validate that, to understand what the norms are. So really what it is now is a time for hospitals to come together, to unite, and you have to hold payers together with the payers' collective data. I'm going to stop. Well, thank you very much. Appreciate the time. And please let me know if there's anything we can do to help you out.